So today we have for our speaker one of our very own faculty. We have Dr. Andy Lincoln here today, who is a native of Westchester, so just up the river. Dr. Lincoln completed her MD at Cornell, then went across to the other side of the country to UCSF to complete her residency. And we're very happy to have her here the past year. And we look forward to working with her in future years. So today, Dr. Lincoln will be talking about clinical reasoning.
Great. Thank you. Okay. So I know everyone's still kind of settling down, which is fine. So as Andrew said, what I'm going to talk to you guys about today is really just an approach to the struggling clinical reasoner. And I sort of put it that way on purpose just to say there are so many different ways to work with somebody who's struggling from a clinical reasoning standpoint, and I'm just going to provide a couple of building blocks for one of them. So just to give a little credence to what I'm going to tell you today, these ideas are mostly not mine. So a lot of this comes from some of you may be familiar with Jeff Weiss, who is a famous teaching attending at Tulane. So he wrote a book that I highly recommend called Teaching in the Hospital, which it's sort of like a primer in how to start working with trainees. This JGym Exercises in Clinical Reasoning website is a really fantastic resource. There are a lot of interactive parts of the site, and a lot of kind of exercises that you can use with trainees. And then also, there's sort of this famous article that gets referenced all the time by Judith Bowen from New England Journal of 2006. So this is kind of an amalgam of those ideas with a few of my own things thrown in. So who recognizes this? Yeah, so this is the Arc de Triomphe comparison. Really, this is just supposed to say that there are so many different ways to come at this topic. There are just so many different approaches you can take and kind of end up at the same place, which is just helping people. I have a really strong belief people come to the hospital every day. People come to work wanting to get better and wanting to do the best they can. And there are so many different ways that we can help them. And so, as I said, this will just be kind of a couple of tips to help. And then just to say, really what I'm going to talk about today is very much just the tip of the iceberg. So there is so much out there in this field, and it's sort of growing every day. And so we'll talk about a couple of introductory topics, but if anyone's interested, I'm very happy to suggest other references and sort of ways to get involved. So let's set the stage. So today is June 12th. In just 2 short weeks, we're going to have a whole bunch of new trainees, and I know people from different types of programs, so NP, PAs are starting at different times all throughout the year. But we're going to have kind of this big influx of new trainees come the start of July. So I want you all to sort of put yourself into that headspace and say, so this is your new team, and you have your overnight intern who's just admitted somebody who's very complex, and they are so excited to tell you all about them. It's scrubs. Okay. So I want to help you guys not feel like this as you're listening to that presentation and counting the seconds until rounds end, worried about running out of time. I want you to feel empowered to say I can give feedback to any person at any time about any patient to help them get better in their clinical reasoning, and also just to help the team create a better shared mental model of that patient and take better care of them. So this is an idea. This is supposed to sort of represent an idea that Jeff Weiss is fond of, which he calls the upward spiral of competency. And I really love this mental image. And the idea is that by giving interested learners the building blocks to improve, you can help them sort of start out down here and build their own upward spiral of competency. And I really think of that as that's what we do on rounds every day. That's what we do in clinic every day, is try and help people as they expand their fund of knowledge, sort of move up that spiral and become kind of the attendings and specialists and generalists that they're going to become. So I want everybody to keep that image in mind as we go through the talk. So just a bit of a roadmap. So by the end of this hour, I'm hoping that we can all identify core concepts of clinical reasoning instruction. So we'll spend about 10-15 minutes on that. But we're able to, we're going to do a couple of exercises and just demonstrate a familiarity with these terms, mostly just with the core vocabulary. And just to say that the vocabulary I'm using, as I said, it doesn't come from me, and in the medical school, they're actually working very hard to incorporate this into a lot of the teaching that they're doing. So hopefully, as the year goes on, these terms will not be new to your learners as you're on board with them. And then just to apply the tenets of clinical reasoning, to give structured feedback to learners. And we'll talk a little bit about like what are the tools that you already have at your disposal just by way of being like in clinic with someone, of being on board with someone, to help them improve. So we're going to start off with just identifying the core concepts. So I think it's really helpful to just start off and say, what is the role of the clinical teacher? So, Shravani, tell me, when you're a clinical teacher on board, what do you feel like your role is? To teach them, right? But like, what is, so the way that I really like to conceptualize this is to think about type 1 and type 2 thinking. So raise your hand if you've heard of Daniel Kahneman and sort of thinking fast and slow, type 1 and type 2 thinking. So Daniel Kahneman won a Nobel Prize for this very long book where he basically goes over the same concept multiple times and applies it in different ways. And so this type 1 thinking is this like fast pattern recognition. So I think of this as like a jaguar in the jungle, right? Like you're in the jungle, you see something move very quickly, you say, oh my gosh, I have to get away from that, it might be me. And so that can be extremely adaptive. And a lot of that is just pattern recognition. And this is the type of learning that providers, no matter sort of their background, no matter their level of skill, learn just by way of being on wards. But this type 2 thinking is more slow and analytic thinking. So that's like, is it a jaguar or is it actually a kitten that's not going to hurt me? And how do I know that? And I know that because it's small, or I know that because its facial expression is non-threatening. It's sort of breaking down what you see in this type 1 thinking into taking a more analytic approach. So the clinical teacher, in my mind, really, like what you add to rounds is a little bit of the gestalt. Like, do I think that this smells right? But it's a little bit also of like, can I break this down for the learner and can I explain to them what my process is? And this moving between type 1 and type 2 thinking is, Jeff Weiss says, is like, this is the quintessential teacher. The person who's the best teaching attending, who's the best teacher in clinic, is the one who can break this down for learners and explain to them where their process has fallen off or has gone wrong. So then the question becomes, well, how do you do that? How do you explain to learners that you're moving between these two types of thinking? And so in order to try and help everybody do that, we're going to just go through some core vocabulary terms so that we can all speak the same language when we're sort of working with clinical learners. So we're going to cover 3 vocabulary terms. So the first is illness script, the second is problem representation, and the third is diagnostic schema. And people may have different levels of sort of familiarity with these, so feel free to like chime in, call out if you have seen something different or have something to add. So just starting with illness scripts. So every day, every time when I'm on wards, I give my team the same spiel right at the start. And so I tell them, I want you to imagine every single illness as a movie. And I want you to picture it in your mind and picture it unfolding, right? For every famous movie, everyone has their one favorite movie where they know certain things about it, right? So what do they know about it? So they know how it was made, right? We would consider this like advanced knowledge of the movie. People know like where it was shot, who's in it, who directed it, who's in it, and who watches it, right? So like your demographic of people who are watching Legally Blonde is going to be really different than your demographic who's watching Goodfellas. And you have to have a sense of, like, if you're going to show it at a party, you want to know who's actually going to be interested in it. The beginning scene, right? So if you're, now people don't flip through on television as much, but like, if you're flipping channels, you know what the start of your favorite movie looks like, and you know when you want to stop and watch the rest of it. And then you know how the plot unfolds. You know how it ends. You know what happens to the characters. And so I tell teams, right, this is the same thing that you're supposed to know about each of the illnesses you encounter. You want to know the pathophysiology. You want to know how that disease arose, who's in it, right, who gets it, what are the risk factors for people who get that disease. And then the beginning scene, right, you know the difference between the presenting signs and symptoms of, let's say, a COPD exacerbation versus a heart failure exacerbation. You know what questions to ask people. And then how the plot unfolds, just thinking about what the treatment is, what the time course is, and what the prognosis is of that disease. And I really encourage learners to say, like, visualize it as much as you can, and then as you learn new facts about it, you incorporate it into your illness script to make sort of, to move up that upward spiral of competency. So now we're going to, this list of things is going to show up on a lot of different slides, and we're going to move through it with our other core concepts. So really, what is this? This is like if you wanted to look something up and you look it up to date, they organize it in exactly this way, right? Up to date is actually just a wealth of illness scripts. And when I ask residents, like, what are the resources that they're using, the vast majority would say, like, I up-to-date almost everything, which is horrifying in some ways, but also helpful, because I can say, well, great, if you're up-to-dating it, then you're just reading the illness script, and you should be able to sort of learn it, incorporate it, and then teach it to the other people on the team. So now our second vocabulary term, so problem representation. This is, I think, sounds a little bit more foreign, but really, this is just the one-liner. And this is a part of sort of what every clinical trainee goes through in terms of thinking about how do I tell another person about this patient and about their illness. So what goes into the one-liner? So the way I think about the one-liner is like the lens on a DSLR camera. So who here has, raise your hand if you've ever used a camera where you had to autofocus the lens. So a fair number. So if you have a DSLR camera and you take it off of automatic and you put it on manual, it's actually pretty hard to pull things into focus, and you sort of have to know what you're doing. And I think of problem representations and presentations in the same way, right? I can tell if that person really like understands what they're doing or not by the things that they choose to include or omit in their one-liner, in their problem representation. And really what is like the modern correlate of this is Google, right? So if you wanted to search for something in Google, people have sort of a sense of like what would be helpful to put in there, what wouldn't be helpful to put in there. And then I think of, okay, well, how does my search interact with my wealth of illness scripts, which is essentially like the file box of my mind. So the way I think about this is that the purpose of the one-liner is to activate illness scripts. So you want to be able to have your learner tell the team about some patient, and then have for everybody else on the team, before they even tell you what they think is wrong, for everyone else on the team to say, oh, that activated for me this one illness script, this one file folder of information. And then based on that, I can understand how that person is supposed to be treated and what's going to happen to them. So the problem representation in every single presentation for me should answer 3 questions. And that's who is the patient? What is the temporal pattern of that illness, right? Because remembering that different illnesses have different patterns to them and sort of will evoke different illness scripts. And then what's the clinical syndrome that that person's actually presenting with? And the real point of this, right, is I say this all the time because I'm so decision paralyzed in my own life. Decision making is a muscle, and we can help learners either flex that muscle and make it stronger or not. We can empower learners to be able to manage patients on their own or not. And so by forcing people to do this, it's interesting, a lot of the residents hate it, a lot of the interns love it. It helps them develop that muscle and develop that decision making to say, like, I know what's important about this person and I know what the rest of the team should care about. So who is the patient? So for me, that's like the demographics, the risk factors, and the exposures that they have, right? So if somebody presents with cavitary lung lesions, I want to know, have they ever been incarcerated? Do they come from a TB endemic area? Do they have immunosuppression of any kind? And so that fits into your illness script because it's part of the epidemiology. All of these ideas are linked. Then what is the temporal pattern of illness? So Tal, if I said to you, what is the temporal pattern of illness? Are there words that you might use to describe that would come to mind for you to describe that?
It's been going on for this many days.
Yeah, exactly. So is it hyperacute, acute, subacute, or chronic? And for each disease, those have different definitions, right? The definition of chronic diarrhea is very different than, let's say, the definition of like chronic anemia. And that's part of, you can tell how rich someone's illness scripts are by do they actually know those definitions or not. And then the tempo of disease. So is it stable? Is it progressive? Is it intermittent? Is it waxing and waning? So for instance, I just had a patient on service who was admitted as fever of unknown origin. And so she was initially admitted to me and she's had fevers for 7 to 9 months. But actually when we talked about it, it turned out that she had had intermittent sort of waxing and waning fever. She had only been febrile 5 times in the last 7 months. You think of that person very differently as than someone who's febrile every single night, or let's say who's at febrile every 4th night for that long a period of time. And then the last part, the clinical syndrome. And I think the clinical syndrome is a little challenging because the way that we talk about clinical syndromes in sort of common parlance is sort of similar in a lot of ways to how I'm talking about illness scripts. But that being said, it's sort of what are the presenting signs and symptoms and what is the diagnostic testing that goes along with that specific clinical syndrome. So like one example of a clinical syndrome is acute chest syndrome, right? So acute chest syndrome has specific things that that person presents with. There's specific diagnostic testing that goes along with it, but that is still more narrow than the full illness script of sort of a sickle cell food crisis. So again, I'm going to sort of say this over and over, but the most important thing is to make the reasoner decide what they think is important, right? And just remembering, like, you are helping them every time you force them to decide, you're helping them to exercise that muscle of decision making. So how do I do this? Just very concretely. So I tell learners that they are allowed in an initial presentation to tell me three parts of the past medical history that actually contribute to the reason why that person is submitted. We are very lucky at a tertiary care center to take care of people with a lot of medical history, but I don't need to hear about their BPH if they're coming in with chest pain. If those two things are unrelated, then they don't need to put it in their one-liner. They can put it in their past medical history. And so I tell them PMH, three things, and that's it. If they want to include a fourth or fifth, I sort of say I'll let it slide. But I think it's important to be consistent about that because it really does make them choose. So actually deciding what the temporal pattern is, and I tell them they can be wrong, or maybe I'll disagree. A lot of what we do in medicine is sort of subjective, and that's okay. And then commit to a clinical syndrome that's named, and that will be very patient dependent. So the other part of this that becomes really important is to be really specific. And so what I tell learners is that it is much harder for you to look something up if you can't name it. And it's much harder to look up a guideline for a clinical condition if you don't know exactly what that person has. So a good example of this that comes up all the time is AKI on CKD. I tell people there is no person in the world who has AKI on CKD because everybody has a stage of CKD. And so if I hear about AKI on CKD stage 2, I feel a lot less worried than about AKI on CKD stage 5. And it really changes the way I think about that patient, the way I triage them, the testing I get. The same thing with AFib, right? We think of AFib with a CHA-2DS2 5 as being very different than AFib with a CHA-2DS2 1. And just thinking about what is that person at risk for, let's say they're coming from somewhere else and they don't know any of their medications, you might be much more concerned that they're on anticoagulation and haven't told somebody if they have a high CHA-2DS2. Okay, so now moving on. So the third part is diagnostic schema. And really, diagnostic schema is a fancy way of just saying, what is the way that you describe your approach to a problem to a learner? So it can be a structured approach to any problem. You can make it up on the fly, but as long as it's something that helps you organize your thoughts, that means it's something that could help a learner organize theirs. So I think of AKI, right? We often break down into pre-renal, intrinsic, and post-renal. Something like dyspnea, so there are visual organizers, like the dyspnea pyramid is a popular one that's online. Or one that I learned for, while I was in training for altered mental status is MISTO. So I run through that every time in my head. Is it metabolic? Is it infectious? Is it structural? Is it toxin or trauma? Or is it oxygen related? Or CO2? And just by doing that, you can sort of make sure that you are not forgetting something, or at least you're giving a learner a tool in the middle of the night to say, now I feel comfortable that I'm not missing anything major. So there are a lot of schema can exist for one problem. So a great example is anemia, right? You can break it down to microcytic, normocytic, macrocytic, but you can also break it down to are they losing the blood? Are they sequestering the blood? Or are they breaking it down? So a lot of kind of different ways to skin the cat. So now we're going to do a little exercise. So each of you has a paper. So I want you to turn over your paper and turn to the person next to you and share what your favorite diagnostic schema that you would give to a learner who you were trying to teach. So we're going to take 3 minutes to do that. So 12:27, 12:30 we'll stop.
Is it?
No, it's the top part.
Oh,
so there's space for you to draw it if you need.
Oh.
I listened to it. I don't remember what diagnosis.
It's just any structured approach to any problem. So if you say this is how I think about hematuria, any way you would explain it to learners.
It's like the problem and then what's my favorite thing. I like talking about favorite things. Yeah, it's the workout. basically starts off with getting
What are the
whether
dangers?
you have
What are
yeah.
And then like,
Like I like
like
that
we're wrong.
because people
But
don't
it's
think
like,
through it at all.
Instead
Yeah,
of
exactly.
feeling
Just run together. It's like,
the dangerous
yeah,
things you don't
it
want
is,
to
and then it was high, or, you know, like
and then maybe don't like have
of some variety.
maybe have like rules that out like what that's sort of what I do at my own.
It's low, good answer, or like the problem, because I mean, it could be milk alcohol. From there, we talk about using additional testing you do, like T levels, stochastic depth, like, you know, depth for like HRP, all these things. You know, and then obviously growth for like and hypomagnesemia, of course.
Guys, we're gonna take one more minute and then come back.
And then, yeah, that sort of starts to work off. And then there's also part of this that's kind of like, obviously, it's like, you guys can get like 14, and you basically just skip straight ahead to the, this is either primary thyroid or malignant. Let's get all the rest of this. Oh yeah, and I forgot this.
But that's not right.
Yeah, exactly.
And then I feel like
For everything,
then like what else is
so yeah, I usually, you know,
I think it would be worse than that. That's annoying.
I mean, I try to do like a 20-minute one of these every so often. Like, not, so it's not like every patient, every problem gets this, but it's like sometimes you do this.
Okay, we're gonna come back together. So the thing that I hope also we'll all take away is that diagnostic schema, or sort of these ideas, are applicable to anybody who operates in a clinical environment. Right? It's not just for the teaching teams, for the residents. It's for anybody who encounters like AKI, or anybody who encounters dyspnea and has to decide kind of what to do then, or anybody who's training anybody who's going to encounter those things. Okay, so just as a quick recap, so we just covered illness scripts, right? So imagine the illness as a movie. Problem representation, so that's your one-liner, including your kind of 3 most pertinent medical issues that contribute to this, the reason that you're seeing the patient. And then diagnostic schema, just some structured approach to any problem. And all of these can be quite flexible. Okay, so next we're gonna sort of demonstrate familiarity with this vocabulary. And so we're gonna do a second exercise, which is on the bottom half of your sheet. So let's be really concrete about this. So we're going to take 5 minutes, and you guys have on the bottom of your sheet a sample admission H&P, or HPI. So I want to see, can you create a problem representation? You're not going to have to share with the group, so this should be a very low pressure exercise. But can you create a problem representation for this patient? What feedback would you give to this trainee if you could? And just remembering the parts of problem representation. So who is this patient? What is the temporal pattern of illness? And what is the clinical syndrome? And I'll also say, for most patients, in terms of admission notes and things like that, we think of the one-liners really coming just before the assessment plan, but I've sort of included the components here so that you guys could create it. But I want you to also think about, are all of the elements that you would need to create an adequate one-liner actually in this information that you can give? Okay. So right now it is 12:33, so we're gonna take until about 12:38 or 12:40 to do that. And you guys can work with feel free to work with the same partner, a different partner.
So I like to just try to apply my network Chelsea over this page. Another time called. You guys keep start off with PTH and see what's happening. Yeah, I know, but you gotta check, make sure. Alright. So let's just think eliminate all the garbage that's not related to parties here. It's bleeding, it's really relevant. I mean, the history of CAD and PVD and stuff is relevant if they're on, like, any litigation for that. So I guess I would add those into the page. So that's what the history. So the question we get, you get 3 things you got that history. I get that the CAD / PVD is really the same process, obviously. CIA, presumably this person must be
Yeah. You create your own problem, your own one-liner from this video here, and see if it has all the core components. So do you have information you need to craft, and then also giving the person feedback on how they should do it.
So yeah, I think that was feedback that I gave us already. One always be different. It said use asking about history of
Or no, 2 weeks later.
yeah, go there. Prior episode. It's reasonable. Yeah. 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 Also ask about history. This person have like
If they were
scope before is helpful.
like obviously your life,
Obviously, yeah. And then yeah, ask about history of body disorders, obviously liver disease.
I guess they didn't do that. It would be, I guess, I heard to know that that would be a good thing. That was part of the oh, diagnostic. So yeah, I'd say it's just but I personally am okay with writing all of it. They should be writing all of it. Like, it's a favorite here. Yeah, I kind of prefer it because it quickly tells you who they are, but when they say it verbally, I would prefer them to not say all of it.
Well, one of the things we was asking about constitutional.
CAD, TIA, CAD, level class.
So yeah, they've got to ask about like waiver laws.
I would definitely hate when people present all that unless it is relevant to why they're there. It's that, and I really I don't want anyone to say out loud.
Answer.
Yeah.
Yeah.
Okay.
But like,
All right, we're gonna take like 30 more seconds. Yeah, or you can give, so creating your own problem representation and giving some feedback, like are there things you wish had been in here? Are there things you wish hadn't been in there?
Oh yeah. It's just so much feedback. Training.
Like, I don't think I would.
No, of what? Yeah, this stuff is all. Yeah, and this is right. Yeah, I mean this is all not feedback. Just feedback with training is like you could have asked about this.
Okay, we're gonna come back together. So this, I will say this note was like slightly intentionally vague, but at the same time not really that far from some of the things I think we all see on the word sometimes. So does anyone want to volunteer sort of one piece of feedback they might have given the trainee after getting this presentation, or a problem representation? We could start with feedback. I think that's a little bit of an easier.
I guess we were saying any pertinent medication, so sometimes patients,
Yeah.
vascular surgeons will put patients with CVD on dual antiplatelet or, plus minus anticoagulant, so.
Yeah, definitely.
It would be helpful.
Yeah, so does he
Some
have like
pertinent medication.
CAD on aspirin Plavix? Does he have CAD with recent PCI? PVD on aspirin Plavix, definitely. Is there anything in here that you guys feel like is not relevant to GI bleeding?
Well, I don't know if it's relevant or not, because, did he take any medications, during that time? Is this something recurrent that he's had multiple times before? Is
Yeah.
this some kind of, vasculitities that could be related to now his,
Yeah, sure.
who knows?
Yeah, I think for me, one of my own pet peeves is sort of when people include all of this stuff in the first line of the presentation. There are certain things so good to know up front, right? If you get called to a patient's room in the middle of the night, you want to know, they've had a history of like 3 strokes and a TIA, and even though that, I guess, would be relevant to GI bleeding depending on their medication history, but like let's say they've had a serious medical issue in the past, fine, okay to include it. I had one intern who for every single presentation would include osteoarthritis because it was always on the list, and she was like, it's really important, and I was like, it is, but also this person's here for like metastatic cancer, out of control stuff, and like osteoarthritis is not really quite here. So I think probably everybody identified there are a couple of things here in the one-liner that like are up for debate, and there are some things that probably just don't really need to be in there as the first sentence. And then yeah, I mean, I definitely didn't include a lot of kind of pertinent questions, but just to say, I think it's good for everyone to think like, is it important for that to be included up front, right? Every clinical teacher is going to be different, and every clinical learner is going to be different, and a lot of this is just sort of adjusting to different people's styles. Okay, and then just the same idea, like make them decide. I actually think the most important part of this on rounds is not like antagonizing the learner so that they have included exactly what I would include. It's just that I know that they have looked over the available information and they have made some decision about what they think is and is not relevant. And the other reason that's helpful is that then maybe this person didn't think of, does this person have a GI bleed because they're on multiple antiplatelet agents? And that maybe should be a part of how they're thinking about GI bleed in an undifferentiated patient. Okay, so now we're just going to apply the tenets of clinical reasoning to give structured feedback to learners. Oh, yes.
Thank you.
And so we're just going to do this for a couple of minutes. So the point of this for me is really like the tools that you need to A, assess how people are doing with their clinical reasoning, and B, to give them feedback that's actionable are all at your disposal. And mostly they are generated by Epic. So using notes and oral presentations can really help you assess clinical reasoning. And then with your learners, remembering like a lot of the stuff that you say to them on the fly, they may not really absorb. So just thinking about, can you give learners feedback in a format that they can like take home and think about. And so here, I don't think of myself as a rigid person. I think of myself as being like fairly flexible in life, but on rounds, I am super rigid. And I will tell residents that up front on the first day. So I really think like structure is your friend, and it's a friend for you and a friend for the trainee, because then they know exactly what's expected of them as they're presenting. So the assessment plan, for SOAP notes, I say anything you say once in your presentation, you should never say again, because that is a waste of the time that we spend on rounds together. So if you've told me the one-liner once, I don't want to hear it the second time just because you're about to say your assessment plan. And then problems. So as they're listing out their assessment and plan, really I tell them with your problem, you should be as specific as possible. It doesn't take that much longer just to tell me like the actual parts of that person's illness. So do they have cirrhosis, or do they have cirrhosis that's complicated by hepatic encephalopathy and esophageal varices and these other things? And then I tell them you get 2 or 3 sentences max. If you can't explain to me in 2 or 3 sentences what you think is happening to this person and why, then you don't have a good understanding of it. And then that's something that either like you and your senior or you and I should talk about in a different setting, but rounds is not the place to pontificate about what you think might be happening to that person. Or to list all of the things that could possibly be happening just because you're worried that like you'll miss the one that I'm thinking of. So really, this is the decision part. They have to decide what they think is happening. If they're wrong, I tell them, that's fine. This is a safe space. All of these learning environments for residents, for NPs, for PAs, should all be safe spaces where we feel empowered to make a couple of mistakes, because that's the whole reason I'm with them on rounds, is to be there and to catch those things if they happen. And then I just say, what are you doing to diagnose it? What are you doing to treat it? Those are the only 2 things that I need to know on rounds, so that we have the same shared mental model of what needs to happen that day. So I hold them to this during presentations, and then I hold them to it in their notes as well. So these notes that go on and on, I tell them, you know what, if you really need that to write a good discharge summary, that's fine, but also remember that best practices around discharge summaries are to have a concise description of what happened to that person and what relevant imaging they had. So it's not actually helpful to a primary care doctor in their discharge summary to have every last thing that anyone ever thought about them. So I try and really encourage, and if I see the notes are getting long, I try and encourage them to like tighten it up with it. So documentation alarm signs. So I just said like it's a good idea to review the notes. Everyone knows like things are very busy. How can you quickly identify when you think someone might be having an issue? And sometimes people are very adaptive. Like in person, it may seem like they know exactly what's going on, but then their note seems like they have no idea what's going on. So the things I look for are, and this comes directly from Jeff Weiss, this is not from me, but is no committed hypothesis. So is their note just a list of things that could potentially be happening, and it never actually says like this person has a heart failure exacerbation. Hypothesis with no supporting data. So sometimes people are just in a rush, and that's fine. You sort of have to just read your audience. But if there's really no supporting data in there, if they're around, they're just kind of like, I think they're having a heart failure exacerbation. They have no reason why they think that's happening. That's a little bit of an alarm sign. And then notes that only reference the consultants without specifying a specific diagnosis or clinical syndrome. And I think for all of us, this is like a little bit more common if rheumatology is something, but like just, you know, there are some complex diagnoses that are a little hard to understand, but most of the time, like people should be able to put into their own words in some way more than just like room consulting. So now we're sort of finishing up, but so I just wanted to draw you back to this idea of this upward spiral of competency, that like we really as clinical teachers have this ability to shape our learners and help them move up on this path. And then just remembering, so every mistake I think of, it's like an opportunity for teaching. So I want people to make mistakes on rounds, because if they don't make mistakes, then it's a total waste of my time to be there. So we should look at these as really like not as frustrating things at the beginning of the year, but as like every single time that's an opportunity to help that person get better and like become the provider they're going to be. And then just remembering this idea of decision making as a muscle. So I'm going to ask each of you to make a commitment. So please write down, keep in your phone, think of just one thing from this talk, if you think it's appropriate, that you think would be reasonable to try in rounds. So I'm happy to send out slides or to refresh on the things we went over. But I think by making a commitment, especially like the start of the year, the academic years for the residents is just a couple of weeks away, sort of like we could be more mindful of incorporating these things. And I know the residency is also working hard to put all of these concepts into place too with the resident education and with the medical students. So they should know these terms if you bring them up. So these are just a couple of references. And then a couple of people really helped me with this talk. So Andy Coyle helped me a bunch, but he's obviously not here. And then I'm like eternally grateful to Jeffries, but he didn't know. He has no idea I'm actually giving it. Okay. Any questions that I can answer or? Oh yeah.
We'll give you the applause first.